Welcome to Section 8 of the Renal Physiology Review. In Section 8, we will walk through reabsorption in the distal nephron, including the loop of Henle, the distal convoluted tubule, the cortical collecting duct, and the medullary collecting duct. The loop of Henle essentially is divided into two distinct portions, the descending limb and the ascending limb. These two segments have essentially opposite characteristics. The descending limb is permeable to water, but impermeable to solute. The ascending limb is impermeable to water and actively reabsorbs salt in the thick ascending limb. This distinction is important to remember because it is this distinction that allows for the countercurrent multiplier to create the concentrated interstitium, which is essential for the nephron's concentrating ability. In the thick ascending limb, sodium is reabsorbed via the luminal sodium-potassium 2-chloride cotransporter. If you recall, we mentioned that this transporter is also present on the macula densa. The sodium-potassium 2-chloride cotransporter becomes clinically important as it is blocked by the administration of loop diuretics, the prototype being furosemide. The channel activity is also dependent on potassium backleak through the cellular membrane into the tubular lumen. This backleak creates a lumen-positive voltage. The lumen-positive voltage drives the paracellular uptake of other cations, both sodium as well as potassium, but more importantly, magnesium and calcium. This is why, in the setting of increased calcium concentrations in the blood, loop diuretics are often given. Also, this is why, when loop diuretics are administered, the clinical manifestation is not only low potassium concentrations, but also low magnesium concentrations. Importantly, the thick ascending limb is impermeable to water and only permeable to solute. This contrasts to the thin descending loop of Henle, once again allows for the creation of a hypertonic interstitium facilitating urinary concentration. Also, it is important to remember that the thick ascending limb serves as a diluting segment of the nephron, where solute is absorbed alone, and so the urine left in the tubular lumen is more dilute and has less solute concentration. By the time the tubular fluid reaches the distal convoluted tubule, it is thus hypotonic. In the distal convoluted tubule, similarly, only solute is reabsorbed and it is impermeable to water. Sodium is reabsorbed by a luminal sodium chloride cotransporter. Once again, the sodium-potassium ATPase generates the electrochemical gradient that allows sodium reabsorption. This cotransporter is blocked by thiazide diuretics, and therefore the transporter is often referred to as the thiazide-sensitive sodium cotransporter. As I said, the distal convoluted tubule, similar to the thick ascending loop of Henle, is impermeable to water. Therefore, hypotonic tubular fluid is diluted further. This additional separation of sodium and water reabsorption contributes to the nephron's diluting ability. The distal convoluted tubule thus serves as an important diluting segment of the nephron. Beyond the loop of Henle, we have the cortical collecting duct. In the cortical collecting duct, sodium is reabsorbed via a luminal sodium channel, also known as the epithelial sodium channel. Once again, the sodium-potassium ATPase is responsible for generating the electrochemical gradient that favors sodium reabsorption. Importantly, though, sodium reabsorption is not active at all times. Sodium reabsorption is regulated by the function of aldosterone. Aldosterone both increases the number as well as the activity of the epithelial sodium channel. Therefore, drugs that block aldosterone activity will block epithelial sodium channel activity as well. The sodium reabsorbed then creates a relative negative gradient in the tubular lumen. This negative gradient facilitates potassium shuttling out of the cell into the tubular lumen, as well as hydrogen secretion. Therefore, increased aldosterone activity, or increased activity of the epithelial sodium channel, will increase sodium reabsorption, but be coupled with increased potassium excretion into the tubular lumen, and thus urinary potassium losses, as well as increased hydrogen secretion into the tubular lumen, and increased urinary acid excretion. Therefore, aldosterone excess causes a sodium expanded state, as well as hypokalemia, or low serum potassium concentration, and a metabolic alkalosis, or low serum hydrogen concentration, manifested by an increased serum bicarbonate concentration. In the previous section, we talked about proximal renal tubular acidosis. Distal, the other type of renal tubular acidosis, involves dysfunction of the distal tubule. Because of how they were discovered, distal renal tubular acidosis are referred to as type 1, and proximal renal tubular acidosis are referred to as type 2. This is not meant to be purposely confusing. Nevertheless, it often confuses many medical students and residents alike. Distal renal tubular acidosis occurs primarily through impaired excretion of hydrogen in the cortical collecting duct. This can be through many different etiologies. As we said before, sodium reabsorption creates a relatively negative potential in the tubular lumen. This negative potential then facilitates hydrogen as well as potassium secretion. Therefore, if sodium reabsorption is impaired, hydrogen secretion will also be impaired. This is how aldosterone deficiency, or aldosterone blockade, which activates the sodium channel, can manifest as impaired acid excretion, or renal tubular acidosis. Another potential etiology is direct destruction of the hydrogen ATPase, which provides the channel for secretion of hydrogen. The causes can be multiple. In adults, one of the common causes of a distal RTA that is asked on the USMLE Step 1 exam is Sjogren's disease. Sjogren's disease is an autoimmune disease that is primarily manifested by dry mouth, dry eyes. One of the potential renal manifestations can be a distal renal tubular acidosis. In Sjogren's disease, autoantibodies have been found directed at the hydrogen ATPase in the cortical collecting duct. Because of the destruction of the hydrogen ATPase, there is impaired acid excretion, and the manifestation is a metabolic acidosis. Important to remember, while in the proximal renal tubular acidoses, the dysfunction is in bicarbonate reabsorption, in the distal renal tubular acidosis, the primary defect is in acid excretion. The net result is a more severe non-anion gap metabolic acidosis. We will walk more into detail regarding anion gap and non-anion gap and why the acidosis is much more severe in the acid-base portion of this review. Type 4 RTA is another example of a distal renal tubular acidosis. In type 4 RTA, the primary defect is low aldosterone activity, or hypoaldosteronism. Because of a deficiency of aldosterone or aldosterone resistance, there is decreased acid excretion. Also, because of impaired sodium reabsorption, there is decreased potassium excretion, and the manifestation is hyperkalemia. Type 4 RTAs are often also referred to as the hyperkalemic RTA because this is the only RTA that manifests with hyperkalemia. Both the distal as well as the proximal RTA, type 1 and type 2, usually manifest with low serum potassium concentrations. This distinction is important to remember for the USMLE Step 1 exam. Moving forward, we move on to the medullary collecting duct. The medullary collecting duct is divided into outer and inner segments. It's responsible for some sodium reabsorption as well as hydrogen and potassium secretion through the mechanisms previously outlined. However, most importantly, it is the major site of water reabsorption. Water reabsorption in the collecting duct is hormone dependent and hormone regulated. Specifically, the hormone antidiuretic hormone, or vasopressin, increases the permeability of both urea and water in the collecting duct. In the absence of ADH activity, the collecting duct is impermeable to urea and water. This hormone activity in this segment of the nephron allows for the final fine-tuning of urine to create either a concentrated or dilute urine that leaves the nephron. Let's review once again. In the proximal convoluted tubule, primarily sodium is reabsorbed with bicarbonate. Also, glucose, amino acids, phosphates are reabsorbed, coupled with sodium reabsorption. In the thin descending limb of the loop of Henle, only water is reabsorbed, as it is impermeable to solute. Conversely, in the thick ascending limb of the loop of Henle, only solute is reabsorbed through the sodium-potassium 2-chloride cotransporter. The thick ascending limb is impermeable to water. This distinction will allow for the creation of a hypertonic interstitium and allows urinary concentration. Coupled with the sodium-potassium 2-chloride cotransport activity is a reabsorption of potassium, calcium, and magnesium. The urine that leaves the thick ascending limb is slightly hypotonic, as this serves as a diluting segment. The urine is diluted more in the distal tubule through the reabsorption of sodium with the sodium chloride cotransporter. Once again, the distal convoluted tubule is impermeable to water or permeable to solute. The distal tubule is also responsible for a good amount of calcium reabsorption stimulated by the activity of parathyroid hormone. The collecting tubule and the collecting duct are responsible for the final fine-tuning of the urine composition. In the collecting duct and the collecting tubule, sodium is reabsorbed through the activity of aldosterone. Sodium reabsorption is coupled with potassium and hydrogen excretion. Finally, in the deep cortical collecting duct and the medullary collecting duct, water and urea are reabsorbed. This process is active through the activity of ADH, also known as vasopressin. This concludes Section 8 of the Renal Physiology Review.